I was born and raised in Hawaii, and whenever we start a meeting in Hawaii, we start off with an aloha, right, as a welcome. So I'm going to say to the group, for those of you sitting here in the room, as well as the thousands or the millions sitting at home, aloha. So let's hear it back. Aloha. Okay, not bad, not bad. Let's try one more time, right? Aloha. Aloha. Okay, good. Think good thoughts, right? White sandy beach, blue ocean, blue skies, okay? Just think that throughout my presentation because I'm going to get into some really depressing topics. Yeah, exactly. Okay, so here we go. So just a really quick overview of what we're going to be discussing today, right? I'm going to go into California's federated model, which is really how the great state, the great nation of California, right? How we split up the state in terms of the hospital associations. We have 3 regional associations as well as 1 statewide association, right? A little bit about AB 394, that's the actual nurse staffing law that's on the books, and then SB 227, which was passed in effective 2020, which actually kind of updated the nurse staffing law. We'll go into some of the wage indexes and how the nurse staffing ratios have impacted Medicare area wage indexes, right? I know you guys are, HFMA, you guys want to see some data, you guys want to see some numbers, right? Not just words on a page. As well as some other figures from the Bureau of Labor Statistics, Federal Bureau of Labor Statistics, yes. And then I'll also go into some of the COVID-19 numbers, which I was able to aggregate from our member hospitals within our region, and really look at how the staffing ratios impacted our capacity during those kind of 3 surges. And then there's some other fun legislation that California is looking at hospitals. So hopefully, a little spoiler there, right? Time permitting. Okay, so with that, with a clicker, it's not going. Oh, there we go, the federated team. So California is split, like I said, into different regions, right? So I represent 6 counties towards the south, and even though we're known as the Hospital Association of Southern California, it does not include San Diego and Imperial counties, which are along the Mexican border. So they're known affectionately amongst the team as the Hospital Association of Southern California. The way they history that predates me. There's Camp Pendleton. There's a large Marine base that basically separates San Diego from Orange County. There's a reason that base is there, because they don't like us going down south too much, right? San Diego just likes to be San Diego, right? I've got the 6 counties across sort of that little swath in the middle, the purple, right to the little kind of pinkish red, and then Hospital Council of Central and Northern California is essentially the 50 counties north. So they've got a massive geographic area, right? 50 counties. And then we've got the California Hospital Association, which is headquartered in Sacramento, which basically advocates at the state and federal level. So we also have a DC office. Right? We got a staff out there. Fun stuff, right? Just the 4 musketeers, you can call us. Right? So we, at the regional level, actually take care of local policy, right? So we actually advocate at the city as well as the county board of supervisor level, right? Where CHA does state and federal. And you may imagine, well, Paul, you do a lot of state and you do a lot of county and city level. Well, I mean, the city of Los Angeles is 3-point-some-odd million people, right? Our city council actually there in Los Angeles has 15 council members. When we look across like our book of business, I mean, within LA, we've got 88 cities in LA County, 40 of which have a hospital operating within it. The cities in California have been getting way more active in terms of healthcare policy, and hopefully I can touch upon that later. Okay, so into the meat of it. Let's talk about the staffing ratios in California. So, in the land before time, before any of you were born in 2004, staffing ratios came into effect right in California. Now, what happened was that essentially, as I flip through my slides, right, it created a ratio that is shift specific, that is healthcare professional specific, right? So it's this algorithm that every individual hospital kind of has to calculate. They probably need an army of people to figure out, right? How many RNs do I actually need on a per shift basis? And there's no averaging allowed. So if I've got 5 nurses and one has 3 and one has 6, no, you're out of compliance, because at the highest level you're going to have a 5-to-1 ratio in a med surg bed, right? And it goes down to as low as a 1-to-1 ratio, depending on the patient classification, right? So it's constant flux. And what it really, unfortunately, creates for us is really a massive throughput issue. Because what happens is that on the front end in your ED, right, you actually can't admit anyone because of staffing ratios. Because you're trying to figure out, do I literally have enough RNs to be able to capture or really admit an individual, right? So that's really at its core, sort of this friction that it creates. Because on the back end, if I can't discharge a patient, then I can't admit the patient, because I am literally capped out, right? Regardless of whether or not I have the space, right, the actual physical capacity, the infrastructure or not, you can't take another patient. And that's, I'm going to kind of show you some of that later on with some of the data, right? And if you've got a question, please, stop me at any point in time, right? So what do the ratios really look like? Ah, there we go. Now it's working. So you can see, based on the different kind of bed classification, right, the ratio that the RN is going to have. Typically what happens, I can tell you on a daily basis, is if a hospital is out of compliance, the union, the nurse union will basically call the state, right, Department of Public Health, and basically lodge a complaint, right? Your hospital is out of compliance. So the penalties, as you'll see later, is $15,000 per occurrence, and if you're a repeat violator, it's $30,000. So of course the hospitals, right, are constantly monitoring this because they don't want to get hit with a fine. Because trust me, when you're out of compliance, the state is going to know about it, right? And enforcement will happen. And this is basically 24/7. It even covers issues with meals and breaks. And that's typically where it happens the most, because when someone goes on a break, whether it's 15 or 30 minutes, you've got to have sufficient coverage. Otherwise, guess what? The fine is going to happen, right? You're going to get hit with a fine. So you can see the various types. I'm not going to go really into like the descriptions. There are links at the end of my presentation if you ever want to look at it. California Code of Regulations 70217, right, will give you actually a definition of the different bed types, right? And the hyperlink is at the end of the presentation that you can actually click on it. Okay, so you can see again just the different ratios. So on the next slide, what happened in the states? Well, actually. In the infinite wisdom of the state, these ratios existed since 2008. So prior to this, the ratios were actually higher. So the law went into effect in 2004, and that thou cannot have more in a med-surg bed, one nurse per 6 patients. And then in 2008, they said no, it's 1 to 5, right? So you continually have this decreasing ability of nurses to care for patients, which on a patient safety basis, okay, maybe that's a good thing, but from a cost perspective from a hospital, when you do that, all of a sudden I need to hire how many more nurses, right? And we've never been able to catch up. SB 227 was the union's latest attempt at basically trying to put a little more teeth into it, and that's the $15,000 and $30,000 enforcement penalty that I referred to. And we were able to soften the language a little bit because the penalty does allow some flexibility in the sense of, hey, you're the administrator. Yes, we're out of compliance, but I mean, we called every staffing agency that within the state to try and get more labor to come in, right? And basically, you try and prove your case so that you don't get fined, and that didn't exist prior to CHA basically coming in and saying, hey, you've got to soften it because there's extraordinary circumstances where I can't help it if there's a mass shooting somewhere, and all of a sudden we got 17 patients transported to my facility. There's no way I'm going to be in compliance, right? That's impossible, right? So you're able to basically avoid penalties for situations like that. Okay, so here's the area wage index. Here's where I'm going to start getting into some of the actual numbers. And of course, how many of you are familiar with the CMS area wage index? Everyone should be, right? No? Okay, I see a couple of hands. All right. So what I did was I basically went into the IPPS, the impact files, and really just tried to look at, okay, on the top 3, that's 3 different localities, 3 different CBSAs within California, and comparing them to a couple of CBSAs in Alaska and Washington. And what you're going to see is, hey, the wage index in California is kind of high, right, relative to Seattle or even Spokane. In Orange County, where I live, just think Disneyland, that's Orange County. There are actually no oranges in Orange County. Such a, just false advertising, right? They're all gone, right? There's no more orchards left. It's all houses. But they're at 1.26, right? LA is at 1.30, which never makes sense to me because it's way more expensive in Orange County than it is in LA. And then, of course, you got San Francisco up in the Bay. They're at 1.8 in terms of their wage index, right? Crazy. When I went back and actually looked at the numbers before nurse staffing ratios went into effect, so I'm looking at like the 2004, right, public use files. Orange County was at 1.16 for a wage index. LA was at 1.20. The Bay was at 1.52, right? And what was the number here in Seattle and Spokane? It was 1.14, right? So what happened was that over time, what's happened within California is our wage index relative to the national average has continued to accelerate while everyone else is kind of puttering along, right? So Seattle's seen some increase. It went up about 2%. But in LA, it's gone up by about 107% relative to the national average. And in the Bay Area, it's up 115%. So they continue to accelerate faster than everyone else. So I guess the word of caution is that if staffing ratios become mandatory and you really need to staff up, I mean, you are creating essentially a massive demand, whereas the supply just does not exist. So what's going to happen is your wage growth is going to accelerate tremendously, right? And that's what we've seen here in California. I mean, I know the last time we calculated it, and this was 2018, we were estimating that the staffing ratio law cost the state an additional $3 billion, right, for California, right, just by having these additional staff if we didn't have it. This clicker is giving me, oh, okay. Here's some additional data from the Bureau of Labor Statistics, right? So this is May 2021 data. That was the most current year available. You can see what the average salary, right, for a nurse, for an RN within the same kind of respective areas. Historically, I can say that, again, like for Los Angeles, way back before nurse staffing ratios went into effect, I think we were around $60,000, right? In Seattle was actually around 58,000. So there wasn't much of a differential prior to staffing ratios until, but when you look at 2021, there's a pretty big gap all of a sudden, right? 116,000 versus 99,000 in Seattle in terms of a median salary. So again, when you think about your respective systems, is that something that you can afford in terms of knowing that wage growth will happen, right? And it's going to be quick, right? It's not going to be this slow progression. It's going to be huge. So here's something that our state does in terms of, what's funny is they track registered nurse shortage areas, right? So across the state, our statewide department, OSHPD, which is the state Office of State Health Planning and Development, and they recently changed their name during the pandemic to HCI, which nobody remembers, and everyone still continues to refer to them as OSHPD instead of HCI. But what they do is they look at essentially, which areas across the state have a shortage, right, because of the law. And what you see across the state is that, well, 14 out of the 72 areas, and they did something really weird where they came up with 72 different areas, are the only ones without a nurse shortage, right? So essentially, 80% of the state, which represents 75% of the population, lives in an area where there's a shortage of registered nurses. Right. In general, some of our smaller, more rural areas are the ones who don't have a nurse shortage. Go figure. And then, but very few of our larger urban areas actually are kind of hitting the mark. San Diego is one of them. Sacramento is another. And Paso Robles, I don't know, for some reason, wine country doesn't have a nursing shortage. But when we look at areas across the state, particularly in my region, that actually do, if you look in towards the middle with Los Angeles / East LA, right, the ratio is only 433 nurses per 10,000 population. So in the largest metropolitan area in the state and practically within the country, we're less than half of the amount of nurses that we need. When I look at the numbers, there's roughly 32,000 nurses within Los Angeles County, I think, that hospitals employ, right? So just think of the numbers that we need to catch up. And unfortunately, in terms of some of the HR surveys that we do, we're just never going to catch up, right? The shortage is only getting worse because we've got a lot of boomers that are retiring, right? And the nursing schools simply don't have the capacity to ramp up. And that's something that we're trying to address because of the fact that nurse instructors get paid about half as much as what you'd get paid in terms of actual, patient care. So it's like, who's going to give up $120,000 to work for a $60,000 job? There's no way. I mean, I know they would love to do it. They just don't have the economic means to do so. And without that ability to kind of grow more nurses, I mean, again, the shortage only gets worse, and our wage index only increases ever more because of the fact that you've got to continually pay more to recruit and retain your nurse supply, right? And what happens, unfortunately, is that as we look across, like even within LA County as an example, you're going to have the winners and losers within the county, right? Areas that have more Medicare, Medi-Cal, or as we call them, Medicaid populations, don't have the ability. I mean, when I look at the wage index, yes, it's an average, and let's say it's $70 in LA, somewhere around there. But within the county, you've got hospitals that are probably paying an average of $43 an hour versus other systems that are probably paying closer to $100 an hour, right? So how do they retain their nurses? And if they can't, what's going to happen is they're going to start restricting the services that they can provide. So we see oftentimes like the first thing that will get cut, obstetrics, right? So within our inner cities, you actually may not have an OB ward because you've got to have a nurse staffing ratio, and I don't have enough nurses. Right? And Medi-Cal pays for more than half of my births, and the reimbursement stinks, so something's got to give, right, at a certain point in time. So it's actually our areas that have the largest health disparities that are going to see reduction in services because of that. So think wisely, choose wisely before. So here's some more of the data. What I tried to do from our state data set that OSHPD collects is really looking at where do RNs sort of spend their most time, right? And what you're going to see, there's three main groups that the state collects. And of course, nurses, surprise, surprise. I mean, in terms of the blue bars are basically your room and board, right? The different types of rooms. So nurses represent over 70% of total hours. The gap is filled by LVNs or orderlies, right? Nurse aides. It's a little higher in terms of the orange bar because that's essentially the ED, right? And then, of course, it's a little higher in terms of the gray, and I'm colorblind, so I'm making this up in terms of the colors. So if I'm wrong, just call me out on it. But the gray is, as I'm squinting, it is gray, right? Gray, yeah. That one is ambulatory, so it's more like our step-down areas, too. And again, the ratio tends to be higher there because in a med-surg bed, it's 1:5, right? That's why the blue tends to be a little lower. Whereas it's higher ratios in the ED, or it's lower ratios for nurses in the EDs and in some of our specialty areas. A little more in terms of, let's see, a little more in terms of productive hours by cost centers. And this was an interesting one, and it's something maybe even like you can do for your own facility. So I tried to calculate out, like in Los Angeles again, well, how many nurse hours do we utilize on a per patient day basis? Right? Any guess? Anyone wants to guess? How many RN hours per patient day? Right? Okay. No takers? Right? It's about 16 hours of 16 hours that an RN, right, is basically being applied to a patient day. So how do I get there? Well, we got 4.6 million days. I've got 33,000 RNs on a full-time, right, FTE equivalent. So you times that by 2,080. So I got 67.6 million hours divided by 4.6 million days, right? And then what I wanted to do was actually, and unfortunately I didn't have the time, was to actually go back, if I can get the historical data set, and actually compare, well, what was it like in like 2002, 2003, and then measure it out over time, right, to see how did it change, right? What's the delta? Because that way, that's how we can also start to calculate on an annual basis what the added cost is, right? Because I'm going to use 2003 as my sort of like my base year, right? And just build off of that. And I can actually do like a cumulative amount of, well, how much did it cost us over time? because I can easily get an average cost, right, per hour as well, and calculate that out. So now the next part of my presentation really delves into kind of our experience during the pandemic, right? Because we have this hard and fast rule of thou can only take so many patients based on classification, and then you've got this massive COVID-19 global pandemic that hits. The interesting thing in Southern California, which I don't think anyone accounted for, was the fact that there's a lot of retirees that live in Mexico. So we had tens of thousands of additional patients who were sick with COVID that basically came across the border because they have Medicare, right? And they did not want to be treated in Mexico, so they were trying to come across the border sick, right? Sick as a daisy, hitting San Diego and Imperial counties and basically inundated the healthcare system there. And then they were basically asking hospitals as far north as Sacramento, can you take COVID patients? So they were transporting patients, 400 miles north by ambulance, right? Because there were no beds basically in Southern California, believe it or not. So there were waiver flexibilities that the governor did provide hospitals during the pandemic. I would say the unfortunate thing is those waivers, very confusing, because through his proclamation, the governor has power and authority, and then through the Department of Public Health, right, the State Department of Public Health, there's actually 61 public health departments in California, which I can't figure that one out yet either. But the state would basically issue what we call all facility letters, right? So that's sort of like their regulatory guidance in terms of what flexibilities that they're going to provide, right? Not a lot of feedback or input from the actual industry. It's just the regulators saying, this is what you can do. It's like, really? There's no two-way street in this? And really, so they issued these AFLs. So we always looked at it was AFL, All Facilities Letter 20-26. There were 13 iterations of this letter throughout the course of the pandemic. So you basically had to look on like a weekly basis. Did the state update their regulatory guidance or not in terms of what I can do? Because they started off very, very, very broad in the sense of, hey, if you want a waiver from the nurse staffing, you got to fill out a form, right? Typical government, you got to fill out a form. We're going to review it. We'll get back to you in 10 days, right? Whether or not you can do the waiver, 10 days. And then they said, in like version 2, version 2. Version 3, right? We're going to do an expedited waiver process, right? And then finally in version 4, they said, you know what? Now it's December 2020. To heck with it. Just fill out the form. We're not even going to look at it. Do what you need to do. And essentially, this waiver is going to expire February 28th, 2021. Right? And then they also threw in the little disclaimer, but if we feel like it, we're going to rescind this letter a little sooner, which they actually did. Right? So even though they said it was effective to March 1st, 2021, they rescinded the waiver February 8th because of too much pressure from, unfortunately, a number of our unions saying that the staffing conditions were too great. Right? Nurses were taking care of too many patients, and they want to kind of revert back to the 1 to 5 sort of ceiling. Right? Okay, if this clicker doesn't work, I'm going to start making jokes, and you don't want that. Okay, so this was the actual letter that provided us probably the greatest amount of flexibility during the pandemic. So you can see we went from the med surge as 1 to 5. They allowed us to go up to as high as 1 to 7, which actually, when you think about it, is sort of a game changer. Because on the next slide, what I did here was I basically tracked, and I don't know why I did this, and maybe I'm glad I did. I tracked on a daily basis hospital occupancy in 6 counties for 180 some odd hospitals, right? So, and that's the magic of Excel sometimes and Access, but really looking at what you're looking at is the orange line is total occupied beds. So what we'd say heads in a bed. Oh, sorry, yes, question.
So as you saw that 1 to 7 ratio, was there any decline in quality of care or outcomes?
Not that we know of, but it's really hard in a pandemic. I think some of those
exactly even one-to-one comparison.
Mm-hmm. Because when we're looking at it, especially late 2020, early 2021, the mortality rate is incredible, right? Right. So how do you account for that, right? But and then in terms of other just your normal book of business, I mean, you can see with the blue line there, that's the number of COVID confirmed. So, you know, at our peak in the greater Los Angeles area, you know, 15,000 heads in a bed, 25,000 total, right? So COVID was representing 60% of our total hospital volume for a while. So we're not doing, right, all the other procedures anymore. So yeah, I think our cardiac services probably suffered, right? A lot of screening services go down. So those measurements are going to look god-awful, right? And we're actually trying to figure out moving forward, how do we skip 2020 almost as a year of data? And we're trying to use more 2019 and move to 2021, and even just moving to 2022 altogether, because that 2020, 2021 data is not good.
But if it's not affecting outcomes, it'd be good to push back against that ratio.
Good luck.
The data.
Can I try and move that rock? I don't know. In one of the other presentations, we call it a Sisyphean task. Like the previous presentation talked about the 300. I was stuck on. Hey, I just remember the 300. You know, Sparta. We are Sparta. Yeah, you know, it's sort of like a suicide mission almost, or we think it's a Sisyphean task because we kind of roll the rock halfway up the mountain and then that darn thing rolls back down to the bottom again. Unfortunately for California, the labor unions control, they just have a lot of sway, you know, between, and someone said earlier the health plans, yeah, the health plans have significantly more political power than the hospital industry. And we see that, I mean, you know, in terms of our PAC, you know, we may get somewhere about $1 million in donations, and yet the service union by itself has like something like $30 million. So they outspend us 30-1 just right out of the gate, right? So how do you fight that? You know, and unfortunately, it's just kind of moving the other way. I'm thinking almost the exact opposite. They're going to come out with a law that lowers that med-surg ratio to 1 in 4, you know, at the rate they're going, right? And the only pushback we have is the data in terms of the shortage areas. If we got a shortage now, if you lower the ratio even more, well, look what's going to happen there. Right? And it's unaffordable because the wage growth is going to be even higher. I'm going to start paying nurses in Southern California $150,000. That means the Bay Area is going to be $250,000 for an RN at that rate. And they haven't adjusted our Medicaid fee schedule since 2013. It's the same dollar value that they have in terms of the basket, and all they do is redistribute that darn number on an annual basis. And oh, by the way, well, how many? I was talking on my table. How many Californians are covered by Medi-Cal? So again, wage schedule, right? I mean, their fee schedule, 2013. But how many Californians are covered by Medicaid? Anyone want to take a guess? It's a horrific number. It's massive. Come on, somebody take a guess. 40%. 40%, that's pretty good, yep. About 40% of the population, 15 million people in California are covered by Medicaid. Right? So, and you're stuck on a fee schedule from 2013. So we've been advocating just at the state level to say, you've got to put some additional dollars into this pool because guess what? My wages don't look like 2013, right? Especially after the pandemic. So we are stuck when that rock just keeps, the rock didn't just roll down the hill, it ran us over on the way down. Question over here.
Well, yeah, I'm Andrew Booth, Washington State Hospital Association. Okay. We're the next in the
the next pig in the python.
Yeah, for that kind of thing, and you know, in terms of Medicaid, you know, our state pays 2/3 of the actual cost of care and everything else, and I mean, I relate to everything. My wife's a nursing faculty, and you know, and so it is essentially a supply problem. You know, supply-demand problem. And, you know, I think, you know, the thought of ratios is to create a bidding war amongst hospitals, you know, which without increases in supply is just going to increase price and not increase that supply. But what, you know, and so we've been trying to focus on what can be done in terms of, you know, what are the bottlenecks, you know, whether it's nurse educators, you know, those kinds of things to that program. But I guess the question is, you know, in California, does tracking the data, showing the data, does it really make any difference in the political discourse?
We like to think so, because at least there's a number that we can.
Is there a mechanism?
Yeah,
because I think the thought is that if hospitals paid as much as Microsoft does there wouldn't be a nursing shortage, but whether it's a hospital or whether it's a school, I mean, there's a lot of things that, yes, we wish we could hire more, pay more.
Pay more.
But the constraint is, generally what government, what us, I guess, indirectly is willing to pay for healthcare.
Yes.
Which is the constraint that, the hospitals operate under. Has California had any kind of breakthroughs in terms of that understanding?
Breakthroughs or breakdowns?
Well, I think that's the thing. I think there is a sense that people don't like the cost of care, but the problem of what it actually costs to provide care is not their problem, kind of thing. And so hospitals find themselves sort of stuck in the middle between the expectations of what we would like our healthcare to be and what we, whether as individuals, as businesses, as government, as taxpayers, are willing to pay for it. And there's the disconnect between the two. And I don't know.
So I would say the great state of California has probably gone, the pendulum is way too liberal, in my opinion, right? That's my personal opinion. That is not Paul, speaking on behalf of our industry, but it's just, they're actually, and I'll touch upon this later, spoiler alert again, but that OSHPD HCI is actually coming out with an Office of Healthcare Affordability. So we will actually have price caps on a per hospital basis coming our way 2024. And if you exceed your price cap, you're going to get penalized for that. And oh, by the way, you also need to maintain staffing. So it's like, wait, how does that even work? Right? It doesn't. Right? So there's actually penalties for safe staffing ratios, and it's not even just for RNs. They're actually trying to incorporate LVNs and even nurse aides into it too. So, I mean, and everything, they're literally building the plane as they've already taken off, right? And it's like, oh, we'll give you more details later. And it's like, wait, but you're telling me you're going to penalize me already in 2024. You're going to actually calculate a cost target. And we're already, by my book, we're in almost 2023 already, right? And they don't even actually have all the information yet. They're calculating something because the health plans have given them some information, but particularly on the self-funded side, they don't have that information. They said, well, we'll figure something out. So yeah, it's actually, like I said, it's almost even worse. And hopefully you don't go there, because I know Washington is some kind of price commission, right? But yeah, but we're going like hard cap. And hard cap with the exception of, unless your union wages go up higher than the price cap, then they'll give you a break on it, which is really weird. And it's a hard cap unless unions get a bigger pay raise. And then you're allowed some variance. So I hope that answers your question. Whatever happens, I think the motto of this presentation is whatever happens in California stays in California. Do not go north.
It becomes the model.
It does, yeah. Unfortunately, fortunately, it does, right? Because even for our counties around the Los Angeles area, they say when Los Angeles catches a cold and sneezes, then we get sick, because the policies just proliferate, right, from usually LA or San Francisco and just kind of spreads across. And then it moves north, and it moves north typically. Yeah. Yes.
Sorry to make you go back, but the patient hour allocation of nurse time. So the cost allocation is that they're allocating 16 hours of nurse time to a patient per day in the hospital, and that's just because a nurse is nearby. Obviously, a nurse is not in there 16 hours a day, but a nurse is just on call, around, and available.
Yeah, assigned to a particular patient. So it's
Gotcha.
hard and fast rule, right? If you're in the ICU, right, you're limited to 2, right?
Yeah.
Right.
Okay.
Yeah,
Thank
it
you.
just depends where you are. Yeah. And trust me, they know the number to call. 1-800 hospital fine. So going back to the numbers, and great questions, by the way, so thank you for that. Orange line, total heads in a bed. Blue line, right, COVID. And this is adult only, right, so I excluded all pediatric, right, from this. So what you see is that as that blue line to the far left, right, that January, February 2021, as that blue line started to go down, that's when they removed the ability for hospitals to get a waiver, staffing waiver, right? So instead of going out to March, right, 1st, they basically cut it early February. So what happened is that orange line, started falling because, or if I need to abide by staffing ratios, again, I'm limited in terms of the number of patients I can treat, right? So we went from 25,000 on a daily basis to 22,000, just like that. So what happens to those 3,000 people that probably needed hospital care that can't get it within the greater Los Angeles area anymore? Everyone starts deferring their care, right? Because we can never catch up in terms of services now because you're always behind. So what we've seen, and you hear it anecdotally, and we see it in the case mix a little bit here and there, is that the patients that are coming in now are, of course, sicker, right? Because they didn't get in. They should have probably been treated for something 6 months ago. And that's a discussion we always have around the table with hospital CEOs is, where'd all the strokes go? It's like, I don't know. The number of strokes that my hospitals, has seen, right, has gone down precipitously, right? Cardiac cases, everything. It's like, where did they all go, right? Because they're not coming in anymore. I can see my baseline data from pre-pandemic to now. And some service lines are still down 20 or 30%. So,
Everybody got a Peloton, so we all got really.
Oh, I like that. I own the stock, and it is trash right now. Absolute trash. Yeah, going to make me really upset. I was going to address the elephant in the room, too. I'm going to do that right now. I should have done that earlier on, okay? The Hospital Association of Southern California is not responsible for USC and UCLA pulling out of the Pac-12, okay? They're leaving University of Washington and Washington State in the dust, We're not responsible for that, okay? Just want you to know, even though we are in the greater LA area, and we talk to the regents there, here and there, it's like, what were you guys thinking?
You guys could stop lobbying for the hospitals and just lobby at UCLA.
Lobby the Pac-12, right? Or the Big Ten. Yeah, say do not take them. Yeah, because otherwise the policies from the Los Angeles area are going to transplant to the Midwest, and they don't want that, right? Yeah. So here was the, this is just ICU, right? Utilization as well. So because what we're doing in terms of tracking, we looked at total hospital occupancy. We also looked specifically at ICU capacity throughout the pandemic because the state came out with an algorithm where, in terms of the county color codes of what you could do during the pandemic, were based on hospital ICU capacity within your county. So if you exceeded 85% ICU occupancy, and that's where they said, oh, your hospital's a red county now, and you need to, you can't do outdoor dining, and you can't do this, or you can't do that, right? And then as that percentage actually decreased, and they opened it up to, the yellow or green or whatever color code that they used, during the time. And of course, some of that fallout too is like, wow, people got really angry at hospitals because they almost thought that we were the cause of the fact that they had to wear a mask, and a whole bunch of other things. So it was interesting how we went from heroes to zeros in like a matter of like months. Because even though it sounded like COVID was going down, if ICU capacity was still high, because again, you had all these sick people coming in, you still had all these social kind of restrictions, right, going on. And again, once you see that precipitous decline, that's when the waivers go away, and then of course what happens is you see that orange line just started plummeting because ICU ratios are 2 to 1, right? We simply don't have the staff to take care of people, right? And then when the orange line actually blips up, that's because we brought in a whole bunch of contract nurses at $3,000 a day, right, to actually help cover that overage. Right, and again, bidding war amongst hospitals, right? Literally, we'd have a hospital lose an RN to the travel nurse agency, and that individual would go and work at a hospital 30 miles away as a contract nurse. And you would see it constantly all the time. And of course, then you get hospital CEOs screaming at each other across the table because, why are you taking my nurses? Well, I didn't hire them, right? The travel agency did. So, yeah, we're still working through that. And in terms of the overall cost, I wish the data was available for 2021 so we could actually compare, pre-COVID to COVID of how much did the contract labor even cost us. I actually want to be able to aggregate and sum that up because it was billions of dollars before, and OSHPD actually does track it, and it's like, okay, it's going to be tens of billions of dollars now for sure. So here's another thing that we also look at. We had a discussion at our board level of just what does hospital projections look like? Because I don't know what it's like in Washington. California is getting old really fast. And what we looked at was 2019 data. Okay, well, how many, using 2019 as sort of like a baseline, how many hospitalizations per 1,000, right, for Medicare beneficiaries, right? So kind of use, I use it as a 1.0 baseline and just as you look out over time to 2026, all things being equal, right, how much of an increase are we going to see just for Medicare hospitalizations? Because again, we have a capacity constraint, right, in terms of staffing. And of course, Medicare beneficiaries have way more utilization than commercial, right, and even Medi-Cal, Medicaid recipients. So we start looking out over time that our Medicare population, if they continue the way they're going, they're going to start adding 250,000 more hospitalizations a year, and yet we don't actually have the ability to essentially absorb that additional demand, right? So, like, again, like, how do you maintain services to care for this population that's going to need care later, right, 5 years down the line, and yet can we even keep the ship going to actually help them? Because if not, I don't know where they go, right? We're going to need some huge innovation where we start treating everyone on an outpatient basis, right? Or truly expand that hospital at home program, because we simply don't have the infrastructure to actually to care for that population. You look like you have a question. No? I was not in Crazy Rich Asians either, if you're wondering. Okay, I was not cast in that movie.
I
Okay.
was just nodding.
Okay, all right. You're trying to place me somewhere, I know. I was not the lead. I wish I was. My wife wishes I was, actually, too. So here's actually the projections on just looking to 2026, right? Just if the Medicare population continues to grow, right, that's what the numbers could look like for us. And it's like, again, it's just discussion of how do we start preparing our hospitals for a larger geriatric, right, population. So it's always in the back of our mind. Okay, so now I get to go into some of the other fun stuff. This is non-nurse staffing ratios, right? So the California legislature always comes up with something great for our industry, So AB 962, it's hospital supplier diversity. So what they're asking our hospitals, in 2021 was the first year that hospitals across the state had to submit a report, basically informing the state of your supplies and purchases and whatnot, how much of it was for diverse businesses, right? And what they want to do is they're basically emulating what's happening at our public utilities, and even some of our health plans need to demonstrate that they are purchasing services from minority-owned LGBTQ industries. But if you go back to the GPOs, they don't really collect a lot of that information. So it's like, it's another rock and a hard place situation where how do we get this information and how do we actually report it to the state? Because I could tell you how much I spent on masks and gloves. I can't necessarily tell you if it was a diverse supplier or not. In most cases, it's not, right? So it's all publicly available reports that hospitals submit, and the goal is sort of like they want 25% of our purchases to be with, right, minority owned. So it's an ambitious goal. I don't know if we'll get there, but a lot of it is trying to figure out, again, just getting the information to be able to report. That also takes additional FTEs, right? Because it's not something that exists where we can get that type of information readily. So you basically, again, you're adding more administrative cost, unfortunately, onto the system. Whereas and we're always fighting against things like this because the more you place on us in terms of administrative burden means the less money you have for patient care. So that's one of the fun ones. But luckily, there's really no penalty or stick on that one yet, so that's a good thing, right? And it's more just public shaming of, you didn't spend any money on, on a business of color, right, owned by someone of color. AB 1214. So this is another one. So typically, right, if you're a nonprofit, you got your CHNA that you post, right, every 3 years. So now we're going to have, and this includes anyone, right, investor-owned, right, publicly traded hospitals. You've got to report an annual equity report now, right? So that's coming up. So, well, coming up 2023-ish, because again, this is another one where HCI, OSHPD has basically, they started flying the plane as they're building it because they're still telling us what the advisory committee is basically going to require us to do, right? But, you're going to have to come up with this equity report, right, about vulnerable populations. And just, what does it really mean? We actually really don't know a lot aside from what's written in the law, right, until the committee comes out with its recommendations. So a lot of it is trying to figure out, is there a penalty to this too? Like, how do we make sure that we're not adversely, like we do what we need to do in terms of compliance, but at the same time, that's a lot of information that we've got to kind of put together very, very quickly because you're not even telling me what the rules of the game are, right? You look very sleepy. Everyone needs a little cup of coffee or something. Yeah. So here's the Office of Healthcare Affordability that I touched upon earlier in terms of like that hard cap, right? So they're going to start calculating based on all this information that HCI, again, the same office does all these things. They even do seismic requirements for us. That's a whole nother discussion topic. But they're going to look at an individual hospital. So I don't know how many of you track like what's going on in Massachusetts, because they also have their own healthcare cost commission in Massachusetts. They've got price caps or like revenue caps, you know, and it was like Brigham Women and Children's, I think, was like $130 million over. So they've got to figure out and have a corrective action plan to basically address that overage, right? So essentially that's what's going to happen in California is here's your price target, you know, it should be 3%. If you've exceeded it, we're going to penalize you in future years and put you on a performance improvement plan and yada, yada, yada. You know, and again, light on details, it just sounds extremely punitive to the industry because they're really targeting the hospitals on this, right? Drug prices are carved out of this. You know, they're not looking at drug prices. You know, they're just looking specifically hospital industry, right? And a lot of it really isn't, it's almost, again, an issue of, okay, you're targeting the hospitals because 40% of healthcare spend is sort of on that particular industry, right? There's not that many institutions in terms of, you know, there's like 400 some odd hospitals, right? And you're 40% of the spend, so it's like, well, if I hit you with a hammer, you know, then you're going to cure all of healthcare's, right, affordability issues, right? And really it's, you know, and this is where we push back, a lot of it, it's an access issue because you look at, you know, why do they use more ED services at a particular hospital than another? It's because there's no primary care physicians in the area. So of course, what do people do? They're going to end up in the ED where it costs $500, let's say, for a service, when they could have gone to the FQHC or a physician, maybe that costs $100. But they can't because there's no service available. Therefore, unfortunately, we're that provider of last resort where everyone basically comes in, right? So how do you penalize me for the fact that people are going to come in? Right? Because I can't keep them out because of EMTALA, so you know, you're throwing this huge societal burden essentially and asking the industry to figure it out and not giving me the resources to actually do it. So I think that's my last slide, and these are links, but what I was going to do was also talk about, and I didn't want to put it in a slide, that's why, so. It's actually, I had mentioned earlier how cities are getting more and more into the business of healthcare. So literally this past year, what's happened is 10 different cities, 9 cities in Los Angeles County and 1 city in Orange County decided we're going to try and pass minimum wage ordinances for healthcare workers. Okay, so California already has a minimum wage. It was $15 an hour, and now I think it's like 16 something because it's linked to CPI. So for healthcare workers in these cities, and some of these cities only have 1 hospital, right? Because some of these cities are rather small. What is the minimum wage that the service union was pushing for a healthcare worker? Anyone want to take a guess? Was that? No, it wasn't that bad, thank God. Yeah. But so minimum wage, when you think about it, who is earning the minimum wage working in a hospital, right? So environmental services, right? It's our food and nutrition, right? Some of our clerical staff, right? Some of our admin. So on average right now, I would say within the LA area, it's probably $19, $20 an hour, right, for entry-level positions. So they want to kick it up effective immediately upon essentially the ordinance passing, $25 an hour, right? Like literally immediately effective upon, right, passage. And the unions basically had the vote in Los Angeles where they had the majority of the council. They didn't want to even put it on a ballot. They just wanted to pass it and put it into effect. So, and our concern there is, okay, you know, we calculated out, well, what's the differential of an individual making $19 an hour if we kick them up to 25, right? And it's a pretty easy calculation to do because you got all the number of productive hours. And I think we came out in Los Angeles, the city of Los Angeles, actually, that was the first city, came out to something like $400 million, right? If I had to increase the salary of every security guard, janitor, right? 400 million. But what we can't calculate necessarily is if that does come to pass, what's the effect going to be like for my next level, right? The people who are currently making $25 to $35 an hour, who are like my medical technologists, you know, and so that mid-level professionals, they're making $25 to $40 an hour. If unfortunately the housekeeper is making 25, it's like, I ain't making no 25 anymore. I'm asking for 30, right? 35 bucks an hour, right? And so on and so forth until it gets to our higher end, right? Nurses who are already the biggest chunk, if they're making 70 an hour, they're going to be asking in terms of this progression. So it's been 10 cities thus far, and it's been a slog. We've actually filed, and I think Washington has this, right, voter referendums and everything, where you got people at the supermarkets asking you to sign, right? So we actually managed to push a number of the cities to 2024, and it's actually going to be on the ballot. But outside of that, I mean, the council can pass an ordinance essentially whenever they want, and I think it's 60 days upon passage. When the mayor signs it, boom, it goes into effect, right? And so it would set the floor at 25, and then every year subsequently, it's actually adjusted for inflation. CPI. CPIW is what they wanted to use. Yes, sir.
So in Arizona, there was an issue that they pushed for an increase in the minimum wage, and once they did that, people who were making maybe $12 an hour but were on full Medicaid benefits are now making $15 an hour and have been disqualified for Medicaid benefits because they're too far from the FPL.
Yes.
Are there programs in California that these current workers who are at that $19, $20 an hour that they do qualify, not necessarily Medicaid, but they qualify for and benefit from, but are going to be kicked off of that with this type of price or this wage increase? Because in Arizona, they're saying, okay, I make $1,000 a month, but my medical bill is $100 a month, and now I make $1,400 a month, but my medical bill is $800 a month, right? And so now they took one step forward and two steps back by this type of increase without thinking about, holistically what was going on.
Yes.
Is that possible there with those workers?
Yep. So I'm nodding my head because the great nation of California has figured out a solution for that. It's called Covered California. They do have a number of state subsidies that actually would cover, essentially pay for the premiums of those individuals and put them on essentially a commercial plan, right? But there's still going to be some cost sharing because those exchange-based plans, right, it's not 100%, right? I mean, I think if you're like somewhere between 150 to 200% FPL, I think you're on like a 94% actuarial value plan, right? So there's still a 6% copay for those individuals. And yeah, we did look at that. I mean, doing the math of okay, if you're working so many hours, right? Because the FPL at 138%, right? It's for all 48 contiguous states. So, man, if you're making the minimum wage in the Bay, I don't know how you survive possibly. I mean, you're basically buying one burger a month or something, based on the cost there. But yes, I mean, we have a considerable population that would basically fall off of the Medi-Cal rolls into Covered California. So we do see a number of our Medicaid managed care plans that are looking at opening up plans, right, to basically help capture that market that they know is going to kind of shift. Eventually, over time, will shift out. I mean, when the public health emergency ends, right, I mean, that whole maintenance of effort is going to basically kickstart, and we got 15 million people in Medi-Cal now. They're saying we're going to lose 2 or 3 million just on redetermination alone over the next 14 months, whenever that goes into effect. And then where do those people go? I mean, for hospitals, it's an issue of bad debt. Like, I don't even know what kind of coverage all of a sudden an individual has, because that individual doesn't even know they got kicked off of the Medi-Cal rolls, right? Do they sign up for Covered California? I mean, do they even qualify for Covered California subsidies? Because if they're undocumented, they don't. So then we got this whole quandary there. And then, of course, hospitals in California, our charity benefit plan is, hey, you get free or discounted care up to 400% of the FPL in California. So I think if you're under 200, it's automatically free, right? And so it's like, God, I mean, for the industry, it's tough, right? I mean, because of the labor costs on top of the fact that I got to give away free care, and 40% of people are technically in Medi-Cal who are underpaying me. So it's, it's going to be a tough fight. I don't know if I'll be here next year because I can't afford to keep my position, right, at the rate it's going. Questions?
Did you ever track divert with the staffing ratios? Like
Sorry?
hospitals that went on diversion because of staffing ratios? I'm
That's-
just curious because at
that's
some point
a-
in time, the pain from the possible fines you don't have safe staffing, and do you divert, and where do you divert to?
Any willing provider. That's a great softball, because the other issue that staffing ratios create in California is, and I don't know what you call it here in Washington or even in Alaska, we call it APOT in California, because you need a pot to, forget, I won't even say it. We call it APOT or APOD, and it's ambulance patient offload time or ambulance patient offload delay. Just depends on what side of the fence you're on. So it's wall times, because again, it's a throughput issue, right? Of I can't admit a patient because of staffing ratios, so therefore my ED is literally backed up. So we actually run a service, the hospital association does, called ReadyNet, where we actually start tracking inbound ambulances, and we're looking at whether or not, because it's in partnership with our local EMS agencies, looking at, is a hospital on diversion? And they're on diversion because they can't take any patients. So ambulances just start circling the globe, basically. And then, of course, if you're STEMI, or like you need specialty care, then it's tough, because you'll see, and it looks like chiclets right on like a board of just, hey, all these hospitals are red because they're all on diversion. So literally the EMS agency in certain counties the EMS director will kind of pick up a phone and say, no hospital is allowed to be on diversion right now, because 2/3 of you already are canceling all diversion. You're just going to take whoever comes to you. And then the ambulance basically goes to the hospital and will sit there sometimes for hours, right? And you actually can't recycle the ambulance back in service because of that, and because of a throughput issue. And recently what's happened, and it only happens in LA apparently, is that a number of our private ambulances have basically discontinued non-emergent medical transport. Right, so they're not taking patients from hospitals to SNFs anymore, right? Because they don't have the staff, and because their fee schedule hasn't been updated since the land before time. They said, forget it. We're just, we're taking all of our staff. We're going to push it into emergency services, and you're only worsening the throughput issue, because now we can't get people out of the back door of the hospital. So the ambulances continue to stack up on the front, and I mean, some of our EMS directors have tried to literally institute new policies where they'll take away your hospital specialty designation if your APOT time exceeds like an average of 60 minutes. So if you're a stroke center, now I'm going to take away the licensure. You're no longer allowed to be a stroke center. Or a trauma center, I'm going to take it away from you unless you fix that problem. But like, how do you fix the problem, right? It's a supply issue for us. So unless I get more nurses to help me take on the masses, then I can't fix it, right? Yeah. See someone in the back?
So in the state of Washington, one of the things that's been kind of trending here is to meet some of that supply issue. You're seeing hospitals cut services, and then they just shut down that service and move those nurses into their other areas to make themselves whole. Have you been seeing that in California at all? And which is going to create, obviously, more shortage, more backlog. It'll just start trickling through, and probably where you're seeing at that front door of the hospital. Yeah,
so it's, like I said, the obstetrics is probably going to be some of the first, because lower ratios. And then the other issue there is we don't have enough anesthesiologists anyway, so it's one of those issues, like how do you keep that obstetric ward basically in service, right? If I don't have enough nurses. I haven't seen specifically like any other service line that they're looking at. I mean, the question becomes, can you maintain your trauma network? Because that requires so much, in terms of, again, very low staffing ratios. So we're already having issues there because, again, it's a physician call coverage issue too. But I mean, I would say trauma and any of your stroke, STEMI kind of designations are kind of at risk, because do you have the people to do it, And so I think we'll see some of that shake out the next, I would say, 2 years. I mean, just this past week, we had one hospital system within the greater Los Angeles area, and they're a safety net provider. They declared Chapter 11 bankruptcy. They're about 70% Medi-Cal, and they said, nope, we got to renegotiate everything. So they're like sort of like the first kind of push, and we know, right, because we look on a quarterly basis when the hospital financials come out. How many of our hospitals are operating in the red? And within Southern California, I can tell you through, 4 quarters from, let's say, Q3 2021 to Q2 2022, we got about 54% of our hospitals are operating in the red right now, right? So operating, right, net patient revenue plus other operating revenue minus operating expenses, they're negative. So how long can they keep that up? Because what they're doing is, of course, transferring, restricted use or, unrestricted funds to basically pay for operations right now. But that's just not sustainable because eventually they're going to run out of cash at some point in time, right? Or investments. So they can only keep running on that hamster wheel. Well, they can only keep running that Peloton for another for another year or two, and maybe my stock will go up then. Any other questions? Okay, if not, am I the last person holding you back from lunch or the casino or what's going on here? Okay, where's my MC? What time are we at?
I'm failing at the job, I'm so sorry.
Ah, there you are.